welcome to the deep dive. Today we're really focusing in on Addison's disease, also known as primary adrenal insufficiency.
That's right.
If you're studying for your MSRA, think of this as, well, your essential guide to getting this condition clear in your head.
Exactly. We're taking these revision notes, pulling out the absolute must-knows, making it clear, making it memorable.
Yeah.
We'll cover everything, what it is, the causes, spotting it, testing, management, the long view, basically your fast track on Addison's.
Okay, let's jump right in then. Addison's disease. In really simple terms, what are we talking about? What's the core issue?
Fundamentally, Addison's is, well, it's a rare condition where your adrenal glands, those little glands on top of your kidneys, they just don't produce enough of some really crucial hormones.
Which hormones are we talking about mainly?
Primarily cortisol and often aldosterone as well. Think of the adrenals as sort of your body's control center for stress response and electrolyte balance.
And in Addison's, they're just not keeping up.
Exactly. They're underperforming significantly.
And what's the usual reason for this underperformance? Why do they fail?
The number one cause, certainly here in the UK, is autoimmune destruction. So your own immune system attacking the adrenal glands.
Right. Friendly fire.
Pretty much. That accounts for something like 80% of cases. Memory tip. Autoimmune think attack itself at the auto level. It's a key point to remember.
Autoimmune attack. Got it.
Yeah.
Now, you mentioned different types in the notes. Primary, secondary, tertiary. Why is that distinction important?
Yeah, that's really key. It helps you understand where the breakdown is happening, and sometimes it affects the symptoms you see.
Okay.
So primary Addison's, the problem is the adrenal glands themselves, usually that autoimmune attack we mentioned.
Right.
Secondary adrenal insufficiency, the issues upstream. The pituitary or hypothalamus isn't sending enough ACTH, the signal, to tell the adrenals to work.
Okay. The signal's weak.
Exactly. And then tertiary insufficiency is even further up. The hypothalamus isn't making enough CRH to tell the pituitary to release ACTH. Often that's linked to long-term steroid use that's been stopped.
So knowing the type pinpoints the fault in the chain.
Precisely. Key insight. Knowing the type helps pinpoint where the hormonal pathway is breaking down. It guides your thinking.
And the notes also mentioned acute versus chronic presentation.
Yes. Addison's can creep up on you, you know? Chronic symptoms, maybe a bit vague, developing slowly over time.
But it can also hit suddenly.
Absolutely. It can present as a life-threatening adrenal crisis,
Yeah.
especially if someone with underlying Addison's faces a major stress, like an infection or surgery, and their body just can't produce that surge of cortisol it needs. Think. Chronic equals creeping. Crisis equals catastrophic.
You mentioned stopping long-term steroids, potentially causing tertiary insufficiency. That stood out. Why is stopping them abruptly such a risk?
Well, when you're on external steroids for a long time, your body's own system, the hypothalamic pituitary adrenal axis, or HPA axis, it basically gets lazy. It dials down its own production of CRH and ACTH.
Because it's getting the steroids from outside.
Exactly. It becomes reliant. So if you suddenly pull the plug on those external steroids, your own system isn't primed to kick back in immediately. It's suppressed.
Like a muscle that's not been used.
That's a great analogy. It's weak, and it can't suddenly produce enough cortisol on its own, leading to tertiary insufficiency. That's why tapering steroids is so important.
Okay, let's dig a bit more into the why, the etiology. Autoimmune is the big one, 80%. What else is on the list?
Yeah, autoimmune is the main player. But other primary causes, things directly invoking the adrenals, include infections. TB used to be a major cause historically.
Still is in some parts of the world, right?
Definitely. And HIV can also affect the adrenals. Then you have adrenal tumors, though less common as a cause of insufficiency. Certain genetic disorders, too, like congenital adrenal hyperplasia.
Okay.
And as we just discussed, that issue with prolonged corticosteroid use leading to secondary or tertiary problems when stopped.
And just to be clear on secondary causes again.
Secondary is about dysfunction higher up pituitary or hypothalamus. So tumors in those areas, head trauma, surgery affecting those glands, anything that stops enough ACTH being produced.
The notes give a few more specific examples too, some less common ones.
Yeah, beyond the main buckets. For primary causes, you might see metastases, particularly from lung cancer spreading to the adrenals. Meningococcal septicemia, that's Waterhouse-Friderichsen syndrome.
Right.
HIV can directly cause adrenalitis. Antiphospholipid syndrome is another one. And for secondary, it really boils down to pituitary issues or that exogenous steroid therapy.
Okay, so let's nail down the key etiology takeaways for revision. High yield points.
Number one, autoimmune is massive, like 85% in Western Europe. Remember TB's historical significance.
Got it.
Immunologically, antibodies against steroid 21-hydroxylase are found in about 85% of those autoimmune cases. That's a strong marker.
Okay.
And always, always keep exogenous steroids in mind as a potential secondary or tertiary cause.
And that really crucial clinical sign, hyperpigmentation. When does that point towards Addison's?
This is a vital differentiator. Hyperpigmentation, the darkening of the skin, is typical in primary Addison's, but not usually seen in secondary.
Why the difference?
Because in primary, the adrenals are failing, so the pituitary pumps out loads more ACTH trying to stimulate them. A byproduct of ACTH production is MSH, melanocyte-stimulating hormone, which causes the pigmentation.
Ah.
In secondary, ACTH levels are low, so you don't get that effect. Memory tip, primary pigmentation. It's a classic sign. Check the gums, palmar creases.
Interesting mechanism. What about kids? Are the causes different in children?
Yeah, the picture changes a bit. It's rare in children overall, but congenital adrenal hyperplasia, CAH, is the most common cause there, about 72% of cases.
Okay.
Then you've got things like adrenoleukodystrophy, especially in boys, and autoimmune adrenalitis making up most of the rest.
And for patients with AIDS, any specific concerns there?
Yeah, you need to be aware of opportunistic infections hitting the adrenals, CMV, Mycobacterium, avium intracellular, Cryptococcus. And also, crucially, drug interactions in people with HIV can mess with adrenal function tests, so interpreting results needs care.
Good point. Lastly, on etiology, this term CIRCI, critically ill patients.
Right. Critical illness-related corticosteroid insufficiency. This can happen in really sick patients. Think sepsis, ARDS, major trauma, also HIV, and sometimes after using the anesthetic drug etomidate.
So their stress response is just overwhelmed.
Kind of. Their ability to produce or regulate cortisol appropriately during severe illness gets impaired. Diagnosing it involves cortisol levels, maybe a stimulation test, and sometimes giving short courses of steroids can actually be beneficial in septic shock or ARDS in these patients.
Okay, moving to susceptibility. Who's more at risk of developing Addison's? Key risk factors.
Well, having a family history of Addison's is one. Certain genetic conditions like those autoimmune polyendocrine syndromes, types 1 and 2, are the ones to know.
Right, where multiple glands are affected.
Exactly. And having other autoimmune diseases yourself, type 1 diabetes, Hashimoto's thyroiditis, vitiligo, that definitely increases your risk.
Makes sense, given the autoimmune link.
Yeah. Also, any existing pituitary or hypothalamic problems raise the risk for secondary insufficiency. And we keep coming back to it, but long-term corticosteroid use is a risk factor for tertiary issues after stopping.
Any other associated factors mentioned?
Yes, it's much more common in women, over 90% of patients apparently. Having positive adrenocortical autoantibodies means a significantly higher risk, maybe around 50%.
Wow.
And things that can cause adrenal bleeding, like being on anticoagulants or having conditions like antiphospholipid syndrome or severe sepsis, can potentially lead to adrenal destruction.
Okay, let's get into the mechanism, the pathophysiology. What's actually going wrong at the biological level?
So the core problem is damage or destruction of the adrenal cortex. That's the outer layer of the adrenal gland.
Right.
And that damage means it can't produce enough cortisol. And in primary Addison's, usually aldosterone too, think. Cortex compromised, cortisol and aldosterone crisis.
And the knock-on effects of lacking those hormones.
They're widespread. Less cortisol messes up your stress response, glucose control, immune function, lots of things.
And aldosterone.
Lack of aldosterone, mainly in primary Addison's, throws off your electrolyte balance, particularly sodium and potassium and fluid balance. That's critical.
So just to summarize the pathos for primary.
Primary is mostly that autoimmune attack destroying the cortex, leading straight to low cortisol and low aldosterone.
And for secondary, where's the issue there?
Secondary starts higher up. Pituitary or hypothalamus isn't working right, so you get less ACTH signal. That means the adrenals aren't stimulated enough to make cortisol, so low cortisol. But aldosterone production is often less affected or not affected at all.
Why is aldosterone spared in secondary?
Because aldosterone release is also strongly controlled by the renin-angiotensin system, which responds to blood pressure and sodium levels, largely independent of ACTH.
Ah, okay, that makes sense. And the overall impact of just having low cortisol.
It's significant. Your body can't handle stress well, physical or emotional. Energy levels plummet, blood sugar can drop, inflammation might not be controlled properly, affects mood too, and then if aldosterone is also low, you get those dangerous electrolyte shifts.
When a doctor thinks someone might have Addison's, What else might be on their mind? What are the main differential diagnoses?
Good question. Top of the list is distinguishing primary from secondary adrenal insufficiency, as the cause and some aspects of management differ.
Uh,
Congenital adrenal hyperplasia, CAH, is important, especially if symptoms start younger. You might think about other causes of adrenal dysfunction, maybe even adrenal tumors, though they're less likely to cause insufficiency.
and maybe some non-adrenal things initially.
Yeah, conditions causing chronic fatigue, weight loss, low blood pressure, things like severe hypothyroidism, chronic infections, malignancy, even depression could be considered early on before the specific hormonal pattern becomes clear.
Got it. How common is this condition? What's the epidemiology look like, particularly for the UK?
It's considered rare. In the UK, the prevalence is estimated somewhere between, say, 93 and 140 cases per million people.
Okay. And who typically gets diagnosed?
Usually diagnosed between the ages of 30 and 50, and as we mentioned, it's definitely more common in women.
So roughly how many people in the UK are we talking about?
The estimate is around 8,400 people living with Addison's in the UK. And the incidence, so new cases per year, is about 4 per million in Western populations.
Okay. Rare, but clearly important to recognize. How does it actually show up? What are the clinical features we should be looking for?
It can be quite insidious, which is tricky. Common things are this profound fatigue, like exhaustion that rest doesn't fix, unintentional weight loss, muscle weakness.
Okay.
Low blood pressure is key, especially postural hypotension, feeling dizzy or faint when you stand up.
Right, the head rush feeling?
Exactly. And a really classic symptom, especially in primary, is salt craving. That's the body trying to compensate for the aldosterone deficiency.
Interesting. What else?
GI symptoms are common nausea, vomiting, tummy pain, and those electrolyte changes we talked about. Low sodium, high potassium.
And if things get really bad, an adrenal crisis, what are the alarm bells?
It's like a full-blown emergency. You're looking at severe low blood pressure, maybe shock, dehydration, confusion, sometimes loss of consciousness. It's critical.
The notes listed quite a few other features too. What are some particularly useful ones to remember for exams?
Definitely the hyperpigmentation. We talked about where to look: sun-exposed areas, creases like the palms, inside the mouth, buccal mucosa, lips, nipples, recent scars. That's a big one for primary.
Okay.
Loss of pubic and axillary hair, especially in women, can happen. Low blood sugar, so hypoglycemia. Vitiligo patches of depigmented skin often coexist because of the autoimmune link.
Right.
Other things can include diarrhea or constipation, muscle cramps, joint pain, fainting spells, syncope, confusion, personality changes, irritability, and in kids, maybe delayed puberty.
And on physical examination, what are the absolute must-check signs?
Two main things. Look carefully for that hyperpigmentation in the classic spots, and measure the blood pressure lying down, and then immediately upon standing to check for that postural drop, typically a drop of 20 mmHg systolic or 10 mmHg diastolic is significant.
Are there particular situations where you should really have Addison's high on your differential list?
Yes, definitely a few scenarios. One is if a patient with known hypothyroidism seems to be getting worse despite being on enough thyroxine, consider coexisting Addison's, part of autoimmune polyendocrine syndrome type 2.
Ah, good point.
Another is unexplained recurrent low blood sugar episodes in someone with type 1 diabetes. Again, the autoimmune link.
Okay.
Obviously, if someone has other known autoimmune diseases, be more suspicious. And that classic electrolyte combo, low sodium, high potassium, especially with suggestive symptoms, should absolutely trigger thoughts of Addison's.
Okay, so the suspicion is high based on the clinical picture. What's the definitive test? How do we confirm it?
The key investigation, the one that really nails the diagnosis of primary adrenal insufficiency, is the ACTH stimulation test. It's often called the short synacthin test.
Right, synacthin. How does that actually work? What are we measuring?
Okay, so you take a baseline blood sample to measure the plasma cortisol level. Then you give an injection of synacthin, which is basically synthetic ACTH.
Okay.
Then, usually 30 minutes later, you take another blood sample for cortisol. In someone with healthy adrenals, that synacthin injection should cause a big jump in their cortisol level.
But in Addison's?
In primary Addison's, the adrenals are damaged, so they can't respond properly to the ACTH signal. The cortisol level will stay low or only rise very slightly. A failure to reach a certain level, often around 497 to 550 nanomoles per liter, depending on the lab, confirms insufficiency.
And you can check for those antibodies too.
Yes, you can also test for anti-21 hydroxylase autoantibodies. If they're positive, it strongly points towards an autoimmune cause for primary Addison's.
What if you can't do the synactin test straight away? Is there a useful first step?
Oh. Yeah, a morning serum cortisol level, ideally drawn between 8 and 9 a.m. when levels should be highest, is a really useful screening test.
How do you interpret that morning level?
Okay, so if the level is nice and high, say above 500 mmol, Addison's is very unlikely. If it's really low, like below 100 mmol, that's highly suggestive of adrenal insufficiency.
And the gray area.
If it's in between, maybe 100 to 500 mmol, that's indeterminate. You definitely need to proceed to the ACTH stimulation test to clarify.
The notes mentioned electrolyte issues again in the investigation section. How common are they when someone's first diagnosed?
They're pretty common, but not universal. Maybe about a third of undiagnosed patients might show that pattern of high potassium, hyperkalemia, and low sodium, hyponatremia. Low blood sugar, hypoglycemia, and metabolic acidosis can also occur sometimes.
So to pull together the first-line tests when you suspect Addison's.
Right, you typically do. Serum electrolytes, looking for low Na, high K, but remember they might be normal. Blood urea might be up if dehydrated. A full blood count, FBC, might show anemia, maybe eosinophilia.
And the cortisol.
And that crucial 8 to 9 a.m. morning serum cortisol, interpreting it with those thresholds.
Yeah.
100 suggests it, 500 makes it unlikely, 100, 500 needs the synactin test.
Okay, and if that morning cortisol is in the intermediate range, or low, and the synactin test confirms insufficiency, cortisol 497, 550, what then?
The next step is usually to measure the ACTH level itself. This helps distinguish primary from secondary.
How does ACTH help differentiate?
If the ACTH level is high, often really high, it means the pituitary is shouting at the adrenals, but they're not responding. That points strongly to primary Addison's adrenal gland failure.
And if ACTH is low?
If the ACTH is low or inappropriately normal despite the low cortisol, it suggests the problem is upstream, the pituitary isn't sending the signal. That points to secondary adrenal insufficiency.
What about measuring aldosterone? When does that come in?
Aldosterone levels, often measured alongside renin levels, can be helpful, especially if the ACTH result is a bit borderline or unclear. Low aldosterone with high renin strongly supports primary Addison's. In secondary, aldosterone is usually normal because its regulation isn't solely dependent on ACTH.
And imaging. When do you scan the adrenals?
Adrenal CT or MRI is usually reserved for cases of confirmed primary insufficiency where the cause isn't obviously autoimmune, A and G negative antibodies. You'd look for things like adrenal enlargement, masses, calcification suggesting old TB or atrophy.
Are there other tests maybe needed to find the specific underlying cause?
Yeah, depending on the picture. We mentioned adrenal autoantibodies for autoimmune cause, chest x-ray maybe for lung cancer mets, abdominal x-ray for calcification, TB.
And if you suspect secondary?
If you suspect a central cause, low ACTH, you'd need an MRI of the pituitary and hypothalamus to look for tumors or other lesions. You'd probably also check other pituitary hormones, TSH, prolactin, gonadotrophins, to look for wider pituitary failure, panhypopituitarism.
Any specific tests for certain groups?
Yes, in young males presenting with adrenal insufficiency, it's really important to screen for adrenoleukodystrophy by measuring very long-chain fatty acids.
Okay. And finally, associated diseases. Does Addison's often travel with other conditions?
Absolutely. Because autoimmune is the most common cause, it frequently partners up with other autoimmune conditions.
Like what?
Thyroid problems are common: Hashimoto's or Graves', type 1 diabetes, pernicious anemia, vitiligo, premature ovarian failure in women.
And those polyglandular syndromes.
Exactly. Patients might fit into polyglandular autoimmune syndrome, type 1, Addison's, hypoparathyroidism, chronic candidiasis, or type 2, Addison's, autoimmune thyroid disease, and or type 1 diabetes. Always worth screening for related conditions.
Right, okay. We've thoroughly covered diagnosis.
Yeah.
Now the crucial part, how do you manage Addison's disease?
Management is all about lifelong hormone replacement therapy. That's the absolute cornerstone.
Replacing what's missing.
Precisely. You need to replace the deficient glucocorticoid, which is usually done with hydrocortisone because it's chemically identical to natural cortisol.
And if aldosterone is also low, like in primary?
Then you also need mineralocorticoid replacement, typically with a drug called fludrocortisone, to manage salt and water balance.
How do you figure out the right doses and schedule?
That's key. It has to be individualized. The dose of hydrocortisone usually split into 2 or 3 doses a day, and the dose of fludrocortisone, usually once a day, are adjusted based on the patient's symptoms, blood pressure, electrolytes, and overall well-being.
So regular monitoring is essential.
Absolutely. Regular follow-up with an endocrinologist is needed to fine-tune the doses,
Yeah.
and huge emphasis on patient education, stress management, adjusting doses during illness, and critically, having an emergency hydrocortisone injection kit and knowing how to use it.
Let's focus on primary Addison's management. What's the standard replacement regimen look like?
So for primary, you need both glucocorticoid and mineralocorticoid. Hydrocortisone is typically given orally, aiming to mimic the body's natural rhythm. Maybe 15-30 milligram total per day, often split like 10 milligram morning, 5 milligram lunchtime, 5 milligram late afternoon.
And the fludrocortisone.
Fludrocortisone is usually once daily, maybe 5,300 micrograms, dose adjusted based on blood pressure and electrolytes, especially potassium.
And patient education is vital here.
Paramount. They must understand they can't miss doses. They need to carry a steroid emergency card, wear a medical alert bracelet or necklace. This information is life-saving.
What about when someone with Addison's gets sick, like a cold or flu?
That's where the sick day rules come in. For any significant illness, fever, infection, injury, they generally need to increase their hydrocortisone dose.
Ouch.
Usually double their normal daily dose, sometimes treble for severe illness for the duration of the illness and until they're fully recovered.
And fludrocortisone.
Fludrocortisone dose usually stays the same. Unless there's significant vomiting or diarrhea leading to dehydration, then they need medical advice quickly.
Okay. And the worst case scenario? Adrenal crisis. Immediate management.
Act fast. It's a medical emergency. Priority 1 is intravenous hydrocortisone, usually 100 milligrams stat. If you can't get IV access immediately, give it intramuscularly.
And
yes, simultaneous FARV fluid resuscitation is critical, usually 0.9% saline, maybe with added dextrose if their blood sugar is low. Rapid volume replacement is key to support blood pressure.
and finding the cause.
Absolutely. While treating the crisis, you must look for and treat the underlying trigger, usually an infection or other major stressor.
The notes mention mimicking natural hormone release more closely. How is that done pharmacologically?
Yeah, the split dosing of hydrocortisone, larger dose in AM, smaller doses later, is the standard way to try and mimic the natural diurnal rhythm of cortisol.
Are there other options?
Some newer modified release hydrocortisone preparations aim for a smoother, once-daily profile, but standard hydrocortisone in divided doses is still very common. Fludrocortisone's longer action means once daily is fine.
And what about DHEA replacement? Is that standard?
Not standard, no. Dehydroepiandrosterone, or DHEA, is another hormone produced by the adrenals. Replacement might be considered by a specialist, particularly for women with primary Addison's who have ongoing issues like low energy or libido, despite good hydrocortisone or fludrocortisone replacement.
But it's not routine.
No, it's unlicensed for this use in many places. The benefits aren't clear-cut for everyone, and it's definitely a specialist decision. Doesn't affect mortality.
Patient education keeps coming up. What are the absolute must-knows for patients?
Okay, core messages. Understand the disease, why lifelong treatment is vital. Medical alert and steroid card non-negotiable, wear carry them always.
Education.
Take meds consistently, never stop abruptly. Know the sick day rules inside out when and how to double or treble the hydrocortisone dose.
Emergency preparedness.
Have an emergency hydrocortisone injection kit. Know how to use it, and make sure a family member or friend knows too. Get travel advice, carry extra meds, letters.
What about long-term follow-up? What does that involve?
Usually annual review with endocrinology, maybe more often if needed. They'll check symptoms, weight, blood pressure, lying and standing, look for pigmentation changes.
Any blood test.
They'll check electrolytes, maybe renin levels, to guide fludrocortisone dosing. And they'll assess if the hydrocortisone dose feels right, not too much, not too little. Plus, screening for those associated autoimmune conditions periodically.
Let's just hammer home the educational support again. Key elements.
Medical alert identifier, steroid emergency card, crystal clear understanding of sick day rules, double trouble hydrocortisone, and practical training for patient and family on using the emergency hydrocortisone injection. That last one can literally be a lifesaver.
Okay, let's quickly revisit adrenal crisis management just to lock it down.
Right. Acute, life-threatening, often worse in primary due to lack of both cortisol and aldosterone. Think profound hypotension, shock, confusion, maybe abdominal pain, fever.
Treatment priorities.
Immediate IV hydrocortisone, 100 milligram, and rapid 5e fluids, 0.9% saline plus dextrose. Don't delay. Find and treat the cause. Expect blood pressure to start improving within hours if treated properly.
And who's typically in charge of managing Addison's long-term?
Initial diagnosis and major changes are usually by an endocrinologist, But once someone's stable and well-educated, the GP often handles repeat prescriptions and advises on sick day rules, liaising with the specialist team as needed. It's a team effort.
What's the general outlook for someone diagnosed with Addison's? What's the prognosis?
With proper lifelong hormone replacement and good self-management, the prognosis is generally very good.
Normal lifespan.
Yes, most people can expect to lead full, active lives with a normal life expectancy. The outcome can depend a bit on the underlying cause and any other health issues, of course.
Are there any caveats?
Well, there is an increased mortality risk associated with adrenal crises, especially in younger patients if triggered by severe infection and not treated quickly. So, preventing crises through education and prompt action is vital. But overall, with good care, the outlook is favorable.
And if it's not managed well, or goes untreated, what are the main complications we worry about?
The biggest, most immediate danger is adrenal crisis. It's a major cause of hospital admission for people with Addison's and can be fatal if treatment is delayed.
What about longer-term issues?
Reduced quality of life is a significant factor. That persistent fatigue can really impact daily activities, work, social life. Loss of libido can occur. The fear of recurrent crises can cause anxiety.
Anything else?
There's a potential risk of osteoporosis, possibly linked to the steroid replacement itself, though using physiological doses of hydrocortisone aims to minimize this. Low adrenal androgens might also play a role in bone density, particularly in women, but that's still being researched.
Okay, that's a comprehensive run-through. Let's try and boil it all down. What are the absolute key takeaways for someone revising Addison's?
Right, core points. Addison's insufficient adrenal hormones, cortisol plus aldosterone. Most common cause in UK is all autoimmune. Presents with fatigue, weight loss, low BP, salt craving, hyperpigmentation in primary.
Diagnosis and management.
Diagnosis confirmed by ACTH stimulation test, short synacthin. Management equal lifelong hydrocortisone, plus fludrocortisone if primary.
And the critical bit.
Adrenal crisis awareness. Patients and families must recognize the signs and know how to give emergency hydrocortisone. That's absolutely crucial.
Fantastic summary. Really vital information, especially for anyone facing MSRA exams, but also just for clinical practice. Thanks for walking us through all that.
My pleasure.
And for all of you listening and revising, don't forget to check out the resources over at pathophysiology.com and also freemsra.com for more MSRA preparation help. Join us next time for another deep dive.